Good afternoon, everyone. So Smith and Robinson first described the anterior discectomy and fusion using bone graft techniques in various shapes. And then over a period of time, this has evolved with the spacer going from cage plate designs to standalone cages and most recently an anchored cages. There are various pros and cons for each. So the dysphagia rates are highest with cage and plate, post-op hoarseness and dysphagia is most. With the anchored cages, these rates have been very less. Most studies have analyzed the anchored cages against cage plate, but there are very few studies that have looked at standalone and the anchored cages and what is the additional benefit of such anchored devices. So the aim and objective of the study was to compare the radiological and clinical outcomes between two subsets of patients who are undergoing ACDF, one treated with standalone cages and the other with anchored cages. It was a prospective, non-randomized controlled trial, consecutive recruitment between Jan 19 to December 20. Only degenerative single-level pathology were included. We excluded infections, tumors, traumatic cervical cord injuries, and revision surgeries. So clinical endpoints of assessment were neck disability index and the VAS score for the pain, quality of life with SF36. Myelopathy was assessed with the modified Japanese Orthopaedic Association score, and the dysphagia was assessed using Bharath's criteria. Radiological assessment was global lordosis, segmental lordosis of the index level of operation. We defined two criteria, subsidence. So any increase of more than 2 centimeter in the disc height or decrease in the disc height would suggest an indication for subsidence, and a change from the anterior vertebral corner to the tip of the anterior portion of the disc by more than 2 mm from the first postoperative X-ray was considered to be a case of cage migration. Results for the clinical outcomes for the NDI, VAS score and MJO score, both anchored group and standalone group showed improvement in the postoperative, but between the two groups, there was no statistical significant difference based on the cage design on their clinical outcomes vis-a-vis pain response and also the myelopathy improvement in the postoperative period. For the radiological findings, the global lordosis improved in the immediate post-op at 6 months and was well maintained at 2 years in both groups. Again, between the two cage designs per se, there was no difference in the improvement of lordosis gained as the group at a single level or on the global lordosis for the patients. In terms of subsidence, we did notice a slight difference, which was 2 cases of subsidence in the anchored cages and 4 in the standalone cages. Dysphagia, again, we had most patients had mild dysphagia of about 51, which resolved within a day or 2 of postoperative period. And between the cage designs, again, there was no significant difference in the dysphagia rates. A patient with subsidence, so pre-op, immediate post-op, and 1 year follow-up of the X-ray, showing some subsidence of the cage. This was a standalone cage, but clinically patient did not have any features of recurrent radiculopathy or myelopathy. This was a cage migration where more than 2 mm migration in an anchored group was seen, but again clinically there was no bearing on the results, and the 1 year follow-up X-ray although showed some migration, the patient did not seem to be symptomatic for it in terms of any dysphagia element. In discussion, subsidence rates have been quoted anywhere ranging from 6.8 in anchored cages to 13.7 or so in standalone cages. This was in our series, and if you look back at literature, you can get as high as 66% subsidence. Obviously, depending on the patient cohort, a significantly geriatric and osteoporotic patient cohort may have higher subsidence rates. However, we have noticed that the clinical outcome and fusion were independent of these measures. Most common subsidences were at the superior end plate. This is a comparative review of the literature with subsidence rates comparing with our study. We propose that probably over-distraction, end plate damage, and osteoporosis concomitantly could be impacting factors in subsidence cases. Limitations, it's a small sample size, non-randomized. There is confounding factors of osteoporosis which we have not assessed in this present scenario. In conclusion, anchored cages appear to have an advantage over standalone, especially in lowering possible subsidence rates. However, clinically, the outcomes may not be significantly different with these two different cage designs. Thank you.